And the first speaker is Prof. Rancati from Buenos Aires in Argentina. And I still remember when I was a trainee in Essex with Mr. Ramakrishnan, Prof. Rancati came to Birmingham. And me and some of the other breast surgeons, we just went to Birmingham just to see this gentleman talk. So it's great to have him today. Prof. Rancati, the next 15, 20 minutes is all yours.
Thank you very much, Hassan. Thank you, everybody, for joining us and for this webinar joined by Greta and iBreastBook. So let me share my screen. So this webinar about basics of cosmetic breast surgery, and I will try to cover basics on breast anatomy and aesthetic assessment. These are my disclosures. I'm consultant for Mentor and advisor for Google Health. And which is the message I will try to give in this presentation. It's something that Maurizio Nava has talked about lots of time, and it's about the vertical surgeon concept. I know that among the participants, there are a lot of breast surgeons, oncologic surgeons, and plastic surgeons, and there is always this idea that some things that plastic surgeons make cannot be made by the oncologic surgeons, and the same by the oncologic surgeons about the plastic surgeons. But really, if we think about our patients, the concept of the breast surgeon or a head and neck surgeon, so the vertical surgeon concept is the best we can offer to our patients. So oncologic surgeon must be trained in cosmetic procedures, and plastic surgeons must be trained in oncologic procedures. And so it's the only way that the patient obtains the best of our medical practice. In that way, a plastic surgeon can assure clear margins, look for good outcomes for the tumor site in the initial surgery if he's involved in cosmetic procedures, and knowing the plastic surgeon if radiotherapy will modify this and try to make the best in the first attempt. So we cannot separate anymore these specialties. So these oncological concepts and plastical concepts about simultaneous contralateral treatment and leaving metal clips on a tumor bed of a breast conservative surgery is something that today it's a patrimony of breast surgeons. So it's better always, we know, to make mirror procedures, and the scars are the best in the future if we make this like that. So we will focus on planning, knowledge, and training. And this is the way to work together to obtain the best results. So usually the oncologic surgeon says, I cannot allow the plastic surgeon to perform the mastectomy because he leaves very thick flaps, and this is not oncologically correct. And the plastic surgeon says, I cannot make a good reconstruction with such a thin flap. So is there really a different kind of mastectomies and different kind of flaps? No, it's the same. The flaps and the mastectomy must be the same if made by the plastic surgeon or the oncologic surgeon. It's a matter of training and a matter of concept. So aesthetic breast surgery is not an art. Breast augmentation, breast reduction, mastopexis, neck position, shape and size of the neck, or combined procedures can only be achieved always by a scientific approach. So the best outcome, it's not a matter of the best artistic approach, but of the scientific approach we make. So we have a lot of factors influencing the results in breast surgery, and some of them without your participation as a surgeon. For example, height and weight, the kind of thorax, the breast base, the asymmetries that congenitally the patient has, the areolar diameter, the areolar position, the skin characteristics, cutaneous quality, a kind of ptosis and alteration of the inframammary fold. These are things that will influence the result, whatever you do, just without your participation. So it's something you must be aware before planning, and you must talk to your patient about this, because anatomically Any patient has special characteristics. With your participation, you will influence more these factors and the results in breast surgery. The incision type and the location of the incision, the pocket plane if you are inserting an implant, the surgical technique you are using, if you're dual plane, prepectoral, the implant shape, the volume, the kind of gel, the implant position. So if you make also inframammary fold modification, so you can imagine the amount of different outcomes you can have if you take in account all these different factors. So the anatomical knowledge on vascular pedicles and the anatomical knowledge on basics anatomy of the breast will allow you to have the better results and also to locate the correct incision in the place you want for the best result and the best safe tumor resection. So we have made with Mauricio this animation just to be aware of what usually happens. So if you know that you have your vascular anatomy and the second intercostal artery, you know that the intercostal perforators are extremely important when you decide a breast pedicle. You will notice that the superior pedicle for any mastopexy, breast reduction, on any procedure, on any resection of a tumor in the lower part of the breast, you must preserve the second perforator. The second intercostal artery, it's ideal for superior pedicle when you make a resection in hour 6, for example. The third intercostal artery, also that it's very easy to locate if you can draw it over the skin to know. It's also one of the perforators that you need to preserve if you want to make a medial pedicle. And this is important when you make a resection that will be based the vascularity of the nipple area complex over the medial pedicle. So between hour 1 and 4, you have the third, and perhaps you can also preserve the second one. So in this way, you can have a medial pedicle. Of course, the fourth pedicle, it's also important when you try to make just a medial pedicle. For the superior medical, you have the second and the third. For the medial pedicle, you have the fourth. But if you are making a mastectomy, you will usually cut the fourth pedicle and you will have your vascularization over the second and the fifth. So depending on the kind of resection you are doing, a mastectomy, breast conservative surgery, one of these intercostal artery will assure you vascularization of the nipple area complex. If you are deciding an inferior pedicle because you are resecting a tumor in the upper pole between hour 9 and 6, you must base your pedicle between the fourth and the fifth intercostal artery. So this is extremely important also in the mastectomy. The fifth intercostal, the ICAP, is the important one when you are preserving in a nipple-sparing mastectomy with an superior incision. Because if you cut in the inframammary fold, you are cutting the ICAP, the fifth intercostal. So depending on the pedicle is the decision you make depending on the position of the tumor. Usually, it's contrary to the position of the tumor. If you are taking out a tumor in the lower quadrants, you will make superior pedicles. If your tumor is in the superior pedicles, you will preserve inferior pedicles, or lateral one like this with the lateral thoracic artery. So here you have a picture of the different pedicles depending on the resection. Usually, as you see, contrary to the pedicle is the resection. So this is a very simple way to decide what pedicle you need to preserve in your mastopexy, breast conservative surgery, or breast reductions. So in refinements, in contralateral adjustment, or in complex places, just to filling spaces where you need to mobilize some tissue from the breast to preserve function and sensation, also to have a good closure without suffering, for the color match, to avoid reduce or to deal with asymmetries or with posterior radiotherapy, also to make an autoprothesis, you need to know about basic anatomy of the pedicles. This is everything in breast surgery if you want to have a good outcome and to reduce your complication and morbidity. So if you are looking for an optical result in symmetrization, of course, you are looking for security, predictability, shape, symmetry, upper pole definition, and operation time, and to avoid complications and legal implications of your surgery. For this, it's very important to know the anatomy, to train on the technique you are going to use, and to have the knowledge to select the patient correctly. So forget about if you are planning an augmentation to base your decision just on volume. You know that you must have a biodimensional approach. You must use today form-stable cohesive gels. You must make a precise technique, and you must avoid planning errors when you are approaching the inframammary fold incision, because bad planning is a bad result. Like this patient, where you see a bottoming out and you see where the incisions are located. And also another case, usually you see this at the office every afternoon. And here you see one of the incisions not in place and a previous one there also. So two times locating the incision in any place. And this is bad planning, and this is why you have poor results. So if you do not fix the inframammary fold, you do not take the measures exactly depending on the arc measure of the implant to know where to locate the inframammary fold incision, you will have this kind of results. So also forget about planning a breast reduction based on a freestyle marking. Today, you cannot make any more freestyle marking for breast reduction because you need to know exactly the measures. And the asymmetry in breast, it's something that it's very important to communicate to the patient previous to marking and to the results, and to check what part of the breast is remaining exactly the same in both sides. If not, you will not have a correct and symmetric breast reduction. So for all this, you need the knowledge, and the needed tools to accomplish the best possible result are very simple: the caliper, markers, centimeter, and cookie cutters. So with this, you can perform a correct breast planning if you have in mind what is the technique you are going to use and why. So you have a lot of pre-op factors like defining the strategy and making the definitive decisions before going to the operating room. This is something that it's very important for plastic surgeons and oncologic surgeons to know that the surgery is made in your mind the night before surgery. So you must visualize what you are going to do and not to go to the operating room to make decisions. So you must execute your decisions in the operating room to reduce times and reduce complications. But the decisions are made previously to that. And most of the conflicts you have after this is because you are trying to deal with a problem during surgery. And that's because you have not visualized and decided previously. So you must document on the chart when you have the interview with your patient, a detailed memo on the patient worries, which are the shared decisions with the patient, because if you don't do this and you make a poor planning, you will have no chance to have a good outcome. So surgery is science, not art, and you must make this a systematic way of working. So as pre-op factors like patient selection, education, and planning, you must have consent expectation with your patients. precise marking. It is important to mark your patients in previous, the night before perhaps, to know and to look at the pictures. Sometimes you see the pictures and it's not like what you see when you are in front of the patient. So take the pictures, analyze them previously, and make markings, and take the measures and see if the exact position of the nipple complex is the same, because all these things happen after surgery because you made a bad planning and not a precise marking. So also the technique selection. Does the patient have a previous scar? One of the pedicles is compromised previously by another resection. So all of this is something you must take into account when you share the decision with the patient, to explain why you are making what you are telling the patient is the best for her. So physical examination is very important. And for me, one of the best things that you must take care and communicate to the patient is that tissue characteristic and breast characteristic. For me, this is the most important individual factor when you are working, for example, in a reconstruction or a breast augmentation. Tissue coverage and tissue characteristics tells you what will happen in time. It's not important which happened in the month after, but a year after, you will see different results making the same, just based on tissue coverage and tissue characteristics. So patient selection and precise planning will give you predictable outcomes. It's the only way. It's not a matter of chance and just to see what happens. No, you must know correctly if you select correctly your patients. So also you have intra-op factors in order to reduce your revision rate, because you will have to check this, what's happening with you, what's happening in the last year with your revisions rate. So something that you must try to do is to reduce revision date. And this is the way, just knowing the anatomy, training in different techniques, and selecting correctly your patients. You must have optimal surgical facilities, optimal sedation, optimal instruments, forceps with light, long forceps, optimal materials, minimum surgical time, avoid hypothermia with your patients. This is something important. It's increased the number of infections. For me, it's the intra-op factors. The most important is the optimal surgical technique, to have bloodless surgery, to avoid surgical trauma, to avoid blunt dissections. You cannot use your fingers to make a pocket. Just make everything correctly without having bleeding in your operating field. So avoid decisions in the operating room. If you take decision in the operating room, you will need to order excessive number of implants. You will use the sizers. You will have more cost. You will open unnecessary implants. It's a time waste, more anesthesia time, more contamination for your patient, more medical errors. So you have the risk of choosing a wrong procedure, a wrong marking, wrong materials, wrong medication. So this is something intra-op, you must not take decisions. So if something happens, okay, but if not, in a surgery that you have everything decided previously, you will last very few time, because it's just the time for executing. So you must make your procedures systematic, and this gives you safety in the operating room and a quicker recovery. In the follow-up, the post-op care, it's basically in a close follow-up. If you don't call your patients every night, every day, and you are aware of what's happening, you will have more complications. The time to make a revision is that if you have a patient that tells you that has a lot of pain, it's a procedure that is not so painful, so go and see her. Most of the time, the patients are right when they tell you that something is happening, that they feel something is not correct. So do not waste time with this. So have a close follow-up, have your patient coordinator being aware of what's happening, and call your patients daily. A daily phone contact, at least once a time for you with your patient or with your patient coordinator, will save you of some problems. So permanent close contact for me is my best advice for the follow-up period. And this is a very old paper from McGarney over the 10-year experience aesthetic surgery malpractice claim. And you see, and this is still today the same. So in the last 20 years, 36% of the claims are for the breast. So breast reduction, 17%, breast augmentation, 13%, breast reconstruction, 6%. So we must lower this number. So check yourself and see if you are doing good with this. So which are the top 5 factors for me? Patient education, tissue coverage, scientific planning, precise surgical technique, close patient contact. It's the only way to make things right. And if you are trying after the next presentations, you will hear a new mammoplasty technique, obtain a video to see what details, tips and tricks you have, for example, in an inferior pedicle breast reduction. Visit an experienced surgeon, be in the operating room to see the surgery. Ask the details during the operation. Understand the technique you are using and which are the modifications you might make to have this new approach. And expect always higher revision rate when learning a new technique due to the learning curve. That it was something correct, but if you know this, you will prepare. So as the military says, hard training, easy battle. And think and talk clear with your patients. In an augmentation, measure your mammary base, consider the skin stretch, consider the nipple position, select the incision based on the perforator, measure the lateral diameter, the implant size and characteristics. So make definitive decision. All this must be decided before going to the operating room. If you are talking about reduction of mastopexy, quantify patient's tissue characteristic and limitation and what is the patient desiring as a result. Check previous asymmetries, check sensations pre and post-op. Do not combine simultaneous mastopexy and augmentation if you are not sure of the result, or the patient has a previous reduction or a poor coverage. So have the possibility of staging procedures if you are not sure of the result. So, and differentiate between a second stage and a revision. It's always better to talk about the possibility of a second stage and not to go to the operating room for a revision. So as a conclusion, why must we be focused in delivering the best aesthetic results in breast surgery and be conscious of the anatomy and the basics for breast techniques? To offer the best optimal care to our patients and to reduce the reoperation rate and to reduce the chance of litigation. Thank you very much.